Hello, I'm Professor Giuseppe Querques, a senior consultant at the IRCCS Ospedale San Raffaele and associate professor in the Department of Ophthalmology at the Vita Salute San Raffaele University, Milan, Italy. And today I'm joined by Dr. Khanani, who is Director of Clinical Research at Sierra Eye Associates and Clinical Professor at the University of Nevada, Reno School of Medicine in USA. Together we will be considering recent advances in the care of patients with geographic atrophy with a focus on new and emerging therapies. Today we'll be discussing what is the significance of early identification of geographic atrophy and how we do achieve this. What is the potential impact of new and emerging therapies for geographic atrophy, and what are the key practical considerations for monitoring treatment outcomes and evaluating treatment effectiveness? So let's start with the significance of early identification of geographic atrophy and how we do achieve this. Geographic atrophy is no doubt an increasing global burden, and the GA is the severe form of dry AMD and is associated with irreversible vision loss. Nowadays, it accounts around 5 million people globally. So this late form of AMD is accounting for around 5 million people. But if we project into 2040, this will be representing around 20 million of people affected by GA. The prevalence of GA is dramatically increasing over the age of 75 years. How we do make a general diagnosis of GA? Well, GA is based on fundus examination, and on fundus examination we have a pre-atrophic stage in which we just have drusen that are slowly getting atrophy. Then this progresses to early atrophic lesions, and this lesion slowly progresses towards the fovea, so subfoveal atrophy, and then severe central atrophy. And the diagnosis is based, as I said before, on the basis of fundus examination, so fundus picture, but also fundus autofluorescence and OCT. On a functional point of view, we have best corrected visual acuity, low luminance visual acuity, and Amsler grid together with microperimetry. So now let's discuss with Dr. Khanani about some questions that have been submitted by our audience about the progression of GA and early identification. So Arshad, what is the important to diagnose GA early?
Thank you, Giuseppe. It's great to be here with you. You know, the main reason, obviously, is the fact that this is a disease that will progress in 100% of the patients, 100% of the time. So you and I both know we have patients that we have seen over the last decade. They come in with very good visual acuity and no symptoms, and now they're legally blind from this devastating disease. And we know that the earlier we diagnose, the earlier we can intervene and slow down the progression so we can keep that functional vision and function for these patients. You know, many of these patients, even though they're in their 70s, they're still very active. They want to drive, they want to read, they want to, you know, do their activity of daily living. So I think, you know, we know that this disease will progress obviously at different rates in different patients, but catching it early, diagnosing it early, making sure that we intervene early and do the best we can for our patients, I think it's gonna make them preserve their vision longer. And you know, at this stage in the US, we are doing that. We're trying to get these patients much earlier than we did in the past because now we have treatment options available.
So now we have tools to make early diagnosis, and now we have treatment. So it's extremely important to make early diagnosis of GA. And what about the best way we can make diagnosis of GA, and we can, in this way, ensure diagnosis at the earliest opportunity.
Yeah, as you said very nicely, that we need to do the fundus examination. We need to look at the retina. We need to make sure that patients have geographic atrophy and not other masquerade like Stargardt's or some other disease. But of course, it's examination as well as multimodal imaging. Obviously, traditionally, color photos were utilized. I do use them at initial diagnosis, but my focus now obviously is on OCT. And we use fundus autofluorescence obviously to track the growth, and that has been used in clinical trial as a primary endpoint in terms of growth of lesion. But I think OCT is becoming more and more as the main diagnostic tool for geographic atrophy. Part of it is because you can see early changes, cirrhora, irora, hypertransmission defects. So I think the key is that it's a combination of imaging and clinical examination, as well as history of the patient, right? I mean, you want to know their family history, their social history, as well as knowing their symptoms and how the disease is progressing over time. And I think the key here is that many times, many patients with other diseases get diagnosed with geographic atrophy, and they have Stargardt's and other masqueraders. So, in my clinic, when I see a new patient with geographic atrophy, I'm always thinking to make sure that they have AMD and geographic atrophy and not something else.
So, combination of anatomic diagnostic tools and the functional diagnostic tools may help to make proper diagnosis and a proper early diagnosis and follow-up of our patients. But considering this and the important tools that we have nowadays available for managing our patients, are there any established biomarkers that may help us predict the progression of disease?
Well, I think that's a really good question. Obviously, when you look at the progression of the disease, that it's variable between patients because it's a multifactorial disease where you have genetics, you have social history like smoking and diet and medical issues, and of course, then you have the lesion types. Is it a multifocal lesion? Is there a banded appearance? On fundus autofluorescence. So there are different things that can predict the growth of this. But obviously, when you look at geographic atrophy, you have several different stages, as you nicely mentioned. Is you're looking at RPE changes, you're looking at drusen, you're looking at the size of the drusen, you're also looking at how symptomatic patients are, and as these lesions progress from small multifocal lesions away from the fovea, they come into the center. But of course, when you're looking at biomarkers in terms of imaging, I think it's important to look at imaging and diagnose this early. I think the challenge has been that many times patients come to our clinic too late. And I think now, because of the awareness of geographic atrophy, people are catching small lesions away from the center on OCT. If they're seeing hypertransmission defect, they are getting concerned about, progressive nature of geographic atrophy. And as I mentioned, irora or cirrhora is seen. So I think I'm looking at multiple different things, but all the biomarkers I'm looking at, photoreceptor loss, I'm looking at ellipsoid zone, looking at RPE loss. I think most of this is focused on OCT imaging.
Thank you, Arshad. So you nicely showed how important are these tools and what are the tools that we should use in clinical practice in managing patients with GA, and the way we should use these tools. But now, how frequently we should see our patients with GA, and what is the best way to manage them?
That's a really good question. Obviously, in the past, when we had no treatments, we were seeing these patients every 4 to 6 months, trying to just make sure that, we are looking at their eyes and kind of give them some hope that there are things coming in the future, trying to look at different clinical trials for them, and of course, ruling out any MNV formation in these patients. But now, because we have treatment, we are seeing these patients much more frequently. If I have a new patient coming in today, and I discuss treatment options, I usually don't treat the same day, but I give them the risk and benefits, and we will discuss that about different treatments. But I will bring them back in a few months to kind of discuss that again. In terms of tracking, obviously, clinical fundus examination, visual acuity, and then imaging, OCT every time, and then fundus autofluorescence every time to track the growth. And as I said, color photos, maybe at the initial diagnosis, and maybe once a year, just kind of getting some idea of the historical changes. I think the key here is the fact that we want to look at patients' symptoms as well as their anatomic changes.
Now, Arshad, let's move to the potentially impact of new and emerging therapies for geographic atrophy. And until recently, there were no treatments option for GA, and actually treatments are available in the US until 2023, but not yet in Europe. And this because of many reasons, there was a very long gap to reach the initial treatment. This because it's a challenging disease to treat, and there are still important unmet needs. But again, since 2023, FDA approved in first 2 treatments for GA, that is pegcetacoplan, that was approved in February 2023, and there is a C3 inhibitor, and avansicaptad pegol, that was approved by FDA in August 2023, that is a C5 inhibitor. So now, Arshad, let's discuss some questions submitted by our audience about the impact of new and emerging therapies for GA. So how do new and emerging therapies aim to address the underlying mechanisms of GA, and what progress has been made in the understanding of these mechanisms?
As you mentioned very nicely, the geographic atrophy is a multifactorial disease. It's an age-related genetic disease with multiple components, including social history as well as medical history. And as physicians, we can only target certain things. We cannot, change the genetic biomarker of the patient. We cannot stop them from aging. We can encourage them to stop smoking and control their high blood pressure and cholesterol. But over the last decades, we have had enough evidence showing that by reducing the activity of complement system, we can hopefully slow down the progression. As you know, complement system is hyperactive in patients with AMD, dry AMD, and it leads to inflammation and destruction and cell death. And blocking this pathway may prevent to slow down the damage. And when you look at the complement system, obviously it's very complicated to understand. But in the past, we have had failures if you're just targeting one part of the complement system, like the alternate pathway. And what we have seen is that targeting the key proteins in the complement cascade and shutting the whole system down has actually shown that we will be able to slow down the progression. So when you look at pegcetacoplan, which was the first approved treatment, it targets C3, while avacincaptad pegol, which was also approved in 2023, targets C5, which is more downstream in the complement pathway. But both of these medications are trying to decrease the activity of the overall complement system in an effort to slow down the progression of geographic atrophy.
So, Arshad, now, what are the key data to support the efficacy of the FDA-approved treatments, and particularly in terms of slowing progression of GA?
Yeah, in terms of both pegcetacoplan and avacincaptad pegol, the approval came after the results from their pivotal study. So let's look at pegcetacoplan first. It was studied in 2 large phase 3 studies, the OAKS and DERBY trial. Each of these studies enrolled, around 600 or so patients, and the primary endpoint was obviously reduction in GA growth compared to sham. So when you look at the design of DERBY and OAKS, these were 3-arm studies. In these studies, patients either receive monthly pegcetacoplan or every other month pegcetacoplan, and this was compared to sham. And these are 2-year studies, and the approval came at 2 years, not at 1 year, because at 1 year, one of the studies missed the primary endpoint. But we did see similar benefit in both studies over time, where we saw reduction or slowdown of GA growth, and that benefit continued to increase over time. So when you look at the data from Derby and Oak studies, in the Derby study, patients who were treated with monthly pegcetacoplan over 2 years, they had the slowdown of GA growth by 19%, with the p-value was 0.0004. But this was a nominal p-value because the primary endpoint was at 12 months and not at 24 months. And in the every other month group, it was 16%. While looking at Oaks, we saw slightly more benefit, where we had the 22% reduction in GA growth lesion compared to sham in the monthly group, and 18% in the every other month group. And we have also seen the data from the GALE study, which is the extension study of pegcetacoplan. And what we have seen is that the benefit of this treatment continues to increase over time. And when patients who were treated with sham for 2 years in Derby and Oaks, they were switched to pegcetacoplan in the GALE extension study, we actually saw the benefit in terms of bending the curve of the GA growth, even after starting the treatment after 2 years of sham in these patients. And the other medication that's approved is avacincaptad pegol. This was studied in 2 pivotal studies. GATHER1 was a phase 2/3 study, and GATHER2 was a global, larger phase 3 clinical trials. And when you look at the data from these trials, you have to look at individually, because GATHER1 was an 18-month study and GATHER2 was a 24-month study. So when you look at the data from GATHER1 at 1 year, you see that in patients treated with 4 milligram avacincaptad pegol, the reduction of growth was 27.8%, while 2 milligram was 27.4%. So in GATHER1, we studied both of those doses, and we saw that the benefit in terms of efficacy was similar, but in terms of safety, there was better safety for 2 milligram. That's why 2 milligram was taken forward. And of course, this was compared to sham. This was a 2-part study. And then GATHER2 was the larger phase 3 study, where patients were either treated with monthly avacincaptad pegol or sham through the first year. And in the second year, patients were re-randomized, and patients who were treated with monthly in the first year could get monthly or every other month in the second year, and patients who were treated with sham continued on sham. And when you look at the data from the GATHER2 study, the reduction in GA growth over time was around 14% in the first year. So when you look at both of these studies, one thing that stands out is the fact that we see an early benefit in terms of slowing down GA, and then benefit increases over time. So to our discussion earlier, sooner we start patients on it, the more benefit we're going to achieve, and more preservation of retinal tissue is going to happen. And I think both of these studies highlight that. And there's an extension study of the GATHER trials that's happening, and the data will be presented in the near future.
Arshad, you introduced the safety, the importance of safety for novel drugs for GA. So can you outline the safety profiles of these novel agents, and how do we best manage the associated neovascularization, for example, as a complication of treatments for GA?
That's a great question, Giuseppe, because, as I showed, we are not stopping or reversing the disease. We are slowing down the progression. So the risk-benefit profiles of these agents, as well as safety, is super important. When you look at the data from the Derby and Oak studies, a few things to highlight here. As you mentioned, there's an increased rate of CNV or macular neovascularization, and this is a dose-dependent effect, where we see higher rates in the monthly group compared to every other month group. The other thing we need to look at is intraocular inflammation in the clinical trial. And then lastly, what we have to look at is the rare events, and there were rare events of ischemic optic neuropathy that were seen in these phase 3 studies. But the most common thing I discuss with the patient is choroidal or macular neovascularization, that if they develop that after treatment with pegcetacoplan, they will need anti-VEGF injections. I usually do those injections not the same day, but at a different day. But this is an important part of the conversation. Then we look at the data from avacincaptad, GATHER1 and GATHER2 studies. We also see slight increase rate of macular neovascularization in these trials. But there are a few differentiating points here compared to pegcetacoplan, that we see essentially no inflammation in avacincaptad PAGOL program compared to pegcetacoplan, and I think that's something to keep in mind. We saw one ischemic optic neuropathy. The choice is, when you're discussing, both of these agents, you kind of discuss the efficacy as well as safety. But you and I know that, clinical trials only have certain number of patients, but the real safety of a drug appears in real world. So when you look at the real world usage, after the approval of pegcetacoplan, we saw these rare events of retinal vasculitis that were reported by American Society of Retina Specialists Research and Safety of Therapeutics Committee. And what we saw that they published the report where they had 14 eyes of 13 patients, where all cases had vasculitis after the first pegcetacoplan injection, anywhere from 1 to 3 weeks after the injection. And these patients presented with significant anterior chamber inflammation, vitreous inflammation, retinal vasculitis, retinal hemorrhages, increase in intraocular pressure, and anterior segment neovascularization in many of these cases. And then, of course, we did not see retinal vasculitis with avacincaptad PAGOL in the real world, but, it was approved later. So the great way to look at the safety of both drugs is to look at large databases. And there was a presentation by Matt McCumber at Angiogenesis 2025, where they looked at the large databases from RCA and Mid-Atlantic Retina. And what we saw was something that we saw in clinical trials in terms of differentiator. We saw inflammation slightly higher with pegcetacoplan, but lower than what we saw in the trial, 0.7% compared to 0.2% with avacincaptad PAGOL. They did have 2 cases of occlusive retinal vasculitis out of almost 8,000 eyes. There were no cases seen with avacincaptad PAGOL. And then there were some patients with vitreous inflammation with pegcetacoplan, but they did not see any cases of ischemic optic neuropathy with either of these drugs. So what we know now is that after using these drugs, pegcetacoplan has slightly increased rate of intraocular inflammation, also has the risk of rare events of retinal vasculitis, while avacincaptad PAGOL has a lower rate of inflammation and doesn't appear to have the risk of retinal vasculitis. And I think that differentiation is important when you're discussing this with a patient in terms of risk and benefits of both of these drugs.
So now, what other therapeutic approaches have demonstrated the promising results in clinical trials for treating GA?
We are lucky to have these 2 treatments because it's a very devastating disease. But what we want to do is we want to do better in terms of efficacy, maybe do better in terms of treatment burden, and maybe look at systemic treatment. So currently there is 2 programs that are in phase 3. Number one is ANX007, which was a C1q inhibitor. And in their phase 2 Archer study, they showed vision protection with patients who were treated with ANX007. They did not lose 15 letters as much as the control arm. So that trial is in phase 3. And then the next one is a systemic treatment, alamipretide, which kind of re-energizes the mitochondria to try to recharge them, because we know mitochondria get impacted in dry AMD, and they are the energy source for retinal cells. So that program, which is a systemic subcutaneous injection, is also in phase 3. And then we have early stage program with stem cells and patches of RPE and several other things. We have another program with ABD104, which is a dual mechanism treatment. The trial is fully recruited, and data will be available end of the year in terms of looking at ABD104, which works on macrophages to repolarize them to normal state, as well as normalizing CFH, and that is being compared to avacincaptad PAGOL in a clinical trial. So a lot of excitement.
So now, what are the key practical considerations for monitoring treatment outcomes and evaluating treatment effectiveness? We are assessing treatment outcomes in patients with GA through imaging studies, so fundus autofluorescence and OCT, and we largely discussed about the importance of multimodal imaging, which includes photophotorescence and OCT, but also evaluating function, so best corrected visual acuity, that still has limited value in patients with GA, particularly foveal sparing GA, and the importance of patient-reported outcomes. So the importance of monitoring GA in patients undergoing treatment is related to potential adverse events like development of neovascularization or macular neovascularization, but also identifying other important adverse events that may require treatment discontinuation, like endophthalmitis or ischemic optic neuropathy, but also evaluating GA progression with extension into the fovea, and also ensure risk-benefit balance in patient undergoing treatment, and maintaining patients' compliance and provide education on treatment progression and expectation to our patients. So now, Arshad, let's discuss some questions submitted by our audience about the clinical practical consideration for monitoring treatment outcomes and evaluating treatment effectiveness. So how have treatment goals in patients with GA evolved, and what is your current approach for monitoring treatment effectiveness?
Yeah, the goals have changed. In the past, it was just observation and giving them hope, and now we offer treatment and we are monitoring these patients as we give them treatment in terms of the risk and benefit profile, as well as monitoring the progression. I think as a field, obviously, it's evolving in terms of how do we monitor the growth of the GA in a patient that is being treated with anti-complement drugs. And currently, obviously, most of us are doing is manually with fundus autofluorescence, where we can measure the GA lesion size, at each visit to see how it's progressing. But I think artificial intelligence is playing a huge role now. Not approved yet, many of these softwares, but we have seen where they can track the growth and give us automated, measurements. I think what I tell the patient is the fact that we have their historical growth rate based on, historical fundus autofluorescence and OCTs. And then when I start treatment, I do tell them that they are going to grow. We don't have a treatment that will stop the disease. We don't have a treatment that's going to reverse the disease. But what we can show to them is that the growth is slowing down. Now, obviously, patients want to have no growth, but that's not possibility with these drugs. So that's why it's important to counsel these patients about what are our goals. The goals are to keep function longer, to preserve retinal tissue longer, but the disease will progress. And then, of course, managing the symptoms in terms of slowing down the progression of geographic atrophy, and hopefully their symptoms will not progress fast. And then keeping an eye on the side effects or the risk of these treatment. I think one issue obviously we face is that these are lifelong treatments. As we saw in the data, that the earlier you start, the better, but the longer you treat, the more effect you get. So I think it's a very difficult and different conversation than what we have with our neovascular AMD patient, where it's pretty straightforward about, if you get this treatment, you're not going to go blind, versus if you don't get this treatment, you're going to go blind. Here, things are going to progress at different rates in different patients, but it's important to initiate treatment so we can slow down the progression.
So we said before that multimodal imaging is probably the best approach for following patients with GA. But if you have to choose one or a couple of imaging modalities in terms of sensitiveness and specificity in determining the rate of GA, what imaging modality, what would you use first? And what interval do you consider best for observation?
I think that's a great question. So number one is we use OCT every time, partially because to look for exudation. So that's a side effect. So every time a patient comes in, whether they're on every month or every other month treatment, they get an OCT because we don't want to miss exudation. And then in terms of GA growth, obviously fundus autofluorescence, but I don't do that every visit. I do it every 6 months because we know the GA is not going to change month to month. It may change over a 6 month period. So for my patients who are coming in with these treatments, OCT every month or every other month, every visit, and then fundus autofluorescence to track the growth every 6 months. And I think that fares really well in terms of efficiency and in terms of functional assessment, visual acuity. But we don't do microperimetry or any other assessment. And then, patient reported outcomes, we don't do official ones, but we do ask patients in terms of how their symptoms are doing and the difficulty they're having. Are things progressing or they're kind of steady with treatment?
So, Arshad, you said that it's important to motivate patients in order to get the best compliance for our patients with the GA. So, what are the most important indicators for you and for patients in terms of progression of GA, and also what of these indicators, which of these indicators may suggest you that treatment needs to be adjusted?
So when I'm looking at, the fundus autofluorescence, I'm measuring the GA growth. And I'm also looking at OCT in terms of, photoreceptors and RPE loss. The issue is that all these patients are going to progress, but there are patients who respond really, really well to these drugs, and there are patients who don't respond really well. The problem is, if many of the times we don't have the historical growth rate for these patients, so it's very hard to know how much treatment effect we are having. But I believe that every patient benefits from these treatment. So the key is actually more about giving hope to the patient that you're doing well in terms of treatment, you're not getting any side effects, and we are seeing some slowdown. So it's more about reminding the patient every time that the goal is to slow down the progression. So even if their symptoms are getting worse, I tell them that if they don't get the treatment, the symptoms are going to get worse faster. So I think that's why it's important. It takes a lot more chair time to remind that every time these patients are coming in, that it's something we are trying to avoid in the future is vision loss, and it's important to stay on treatment. But I think if we have historical data of fundus autofluorescence and growth, and now we're slowing it down, I think that serves as a motivator for our patients.
So, actually, you mentioned patient reported outcomes. So, how do you incorporate this in monitoring patients treated for GA?
I think it's very general in clinical practice because we have so many patients. We don't have any official patient-reported outcomes like, we do NEI, VFQ, 25, and other things in clinical trials, but not in clinical setting. I usually ask them, how is their reading, how's their driving, how are their, activities of daily living. So if somebody was driving, they say, I can still drive, or they're still able to read. That's a good thing. So I think we need to find things that patients are doing and they're continue to do while on treatment that serves as a motivator. Listen, this treatment is slowing down the worsening, and you are able to now continue to do your activities of daily living. I think we need to continue the treatment. And of course, we also need to watch for any side effects that are needed. Giving every month treatment is very difficult, especially if you have a bilateral disease. So my protocol is usually every other month treatment with either of the drugs. And I think not only that decreases the treatment burden, but it also decreases the rate of side effects, right? We saw that with pegcetacoplan, it was a dose-dependent effect. We have also seen that with avacincaptad pegol in the second-year data, that every other month had a similar rate of CNV as sham. So I think what we're trying to do is minimize the burden on these patients and maximize their motivation. But yeah, functionally, it's just a very general conversation.
Thank you very much, Arshad, for joining me for this valuable discussion on the recent advances in the care of patients with GA. And I would like to thank all of you for following this conversation. I hope you found it informative.